Good evening, everyone. Welcome to this webinar entitled Pearls, a physical exam with pocket-sized ultrasound for routine use, presented by Janice Boughton and Michael Wagner. The AIUM is accredited by the ACCME. This webinar is designated for one AMA PRA Category 1 credit. By the conclusion of this webinar, participants should be able to give examples of how adding a brief comprehensive ultrasound to the physical exam can change diagnosis and treatment, describe the ultrasound physical using the Pearls mnemonic, and understand the history of how physicians use bedside ultrasound to enhance physical diagnosis. As an ACCME accredited provider, it is the AIUM's policy to ensure that the contents and quality of this activity are balanced, independent, objective, and scientifically rigorous. All individuals who are in a position to control the content of an educational activity are required to complete a disclosure form. All disclosures are reviewed by the AIUM, and any conflicts of interest are resolved or managed prior to an activity. Janice Belton, Michael Wagner, and Darcy Belito de Luna have no disclosures. At the conclusion of the webinar, you will be able to access the CME test and evaluation located on the AIUM website. Participants who complete the post-test with a grade of 70% or higher will be awarded one CME credit. Credits for this webinar are approved for physicians, sonographers, and radiologic technologists. During tonight's presentation, if you have questions for the presenters, you may type them into the question box on the right side of your screen. You will be able to submit questions throughout this webinar, but the presenters will not begin answering until the end of their presentation, at which time they will answer as many questions as possible. A recording of this webinar will be available on the AIUM website. And now we're pleased to present Janice Boughton and Michael Wagner.
So I'm Mike Wagner. I'd like to thank AIUM and ACP for this opportunity to be here today. I'm the Director of Internal Medicine Ultrasound Education at the University of South Carolina School of Medicine, and this talk is about a physical exam with pocket-sized ultrasound that's meant for routine use by just the general practitioner. We have no disclosures at all. And so to start things off, I'd like to talk about my interest in point-of-care ultrasound and how that grew about. Started with a strong desire to improve my physical exam. And as a student and resident, I was very eager to learn the secrets of the physical exam that would help me to become a better clinician. And quite honestly, I was interested in learning about the movement to know about this evidence supporting the signs and bedside maneuvers that I was hearing so much about, and I did want to learn sort of the art of the physical exam, but particularly that which was really rational and actually helped me and the patient. But over the years, my encounters with the masters of physical diagnosis were pretty few and far between, and many of my mentors along the way seemed to fall into this self-proclaimed agnostic category. I was struck by a high degree of subjectivity, not only between different attendings, but also when I was being evaluated on my own skills. And I'll never forget the time this fourth-year medical student, when I was a junior, I thought she was helping us out by walking us through how to kind of fake our way through an ophthalmoscope exam just to pass the OSCE. Things like that, fear and pride, kept us all pretty silent about our inadequacies, often pretending to have heard the murmur or felt the liver edge and things of that nature. And I think a large reason for this acceptance of poor bedside skills continues because there's increasingly obvious and growing gap between what we can diagnose using our traditional physical examination and what is identified using advanced imaging. But this comes at tremendous cost, not just in healthcare dollars and unnecessary radiation for our patients, but also the lost confidence that our patients have in us. In the US, it doesn't seem like we're increasing the spending, or that the increase in spending is helping reduce our diagnostic error. And while I agree that the human touch and compassion as part of the doctor-patient relationship will always be important in medicine. I think to return the emphasis back to the doctor honing the craft of examining the patient, the bedside examination must have both a perceived and an actual diagnostic utility. And I think we need a powerful tool to bridge this growing gap. And I'm here today to talk about why I believe that that tool is going to be ultrasound. So, as a physical diagnosis instructor interested in teaching an evidence-based exam, it is pretty frustrating how often we still teach things that have actually been shown to be unhelpful, like Hohenstein for DVT when the negative likelihood ratio is 0.04 for limited ultrasound. And for those who care for patients in respiratory distress on a regular basis, it's not surprising that the absence of crackles does not help exclude pulmonary edema, or that the presence of crackles is negligibly helpful in determining whether a patient does or does not have pneumonia. Yet we make antibiotic decisions in the clinic based on this all the time, and we make diuresis decisions based on these sorts of things all the time. I do want to mention that these numbers come from a fantastic piece in the Mayo Clinic of Proceedings on point-of-care ultrasound in the primary care, and it's definitely worth a read. So this next article is also a good one. Talks a little bit about internal medicine residents in Norway performing a routine ultrasound exam of the chest and abdomen using a pocket-sized device. And they were able to confirm, correct, or add important diagnoses in 1 out of 3 hospital admissions, which was particularly true when they were examining the elderly population. And so before I say the words pocket-sized ultrasound, so if this is your concept of an ultrasound machine, this kind of Soviet-era monster that takes up half of a room, we need to kind of bring you up to speed. So devices that have very good image quality that fit in the palm of your hand or in a white coat pocket have been around for years, actually, and now are capable of utilizing the same supercomputers that we carry with us everywhere. So this machine plugs into an Android smartphone and runs on an app, and these machines work with Apple products and don't even require a cord. So technology is moving pretty quickly. And so to talk about portable ultrasound becoming kind of like the next stethoscope, it's kind of become cliche at all these ultrasound conferences, but it is really an appropriate analogy. It changed the bedside examination, but for the better, and underwent subsequent continued refinements and improvements over time. And other bedside tools are advancing in a similar way. Residents use their phones instead of pen lights and will likely use them to examine eyes and ears in the very near future. And the evolution of ultrasound in a similar fashion is pretty natural as far as a bedside tool, and it should not be impeded by turf or subspecialty conflicts. So the big 3 ultrasound specialties, cardiology, radiology, and OBGYN, will need to recognize that the massive expansion in point-of-care ultrasound use, predominantly driven by the emergency medicine and critical care folks at this point, that ultrasound is an excellent tool to visualize more than just the heart, gallbladders, and babies. They will have a lot more people to teach, but also a lot to learn themselves, as a now dizzying list of applications exists sort of from head to toe. And this list is certainly not all-inclusive, and it is growing all the time. So should we be ultrasounding people from head to toe? While some have been advocating for something kind of like this since the early 1990s, the question I think remains in 2017, what should a physical exam with ultrasound look like? So in order to understand where we're going, I think we have to understand where we have been. And the history of ultrasound physical exam, in my view, starts here in the loud and often times chaotic trauma bay, where life and death medical decisions need to be made quickly, and where the traditional skills of percussion and auscultation are rendered almost useless. Ultrasound emerged here as a tool to assess for serious organ injury by detecting internal bleeding in the abdomen. And so some of the, although some preliminary work was done in the 1970s. Most of the good early studies on this topic were in Germany during the 1980s, where unfortunately they stayed, possibly contributed to or by language barriers and cultural barriers in the medical community. In the early 1990s, a Japanese study was published in the Journal of Trauma, and soon afterwards a number of American studies that confirmed what was known in Europe for about a decade, and that ultrasound was useful in trauma and could replace the diagnostic peritoneal lavage. And so over the subsequent years, views of the heart were added to assess for hemopericardium, and the modern-day FAST exam was born, looking at the right upper quadrant, the left upper quadrant, the suprapubic views, and the subxiphoid views to look at the heart. And in addition to the catchy name FAST, another important factor in its spread was the inclusion into ATLS training. And that kind of got the ball rolling, and with widespread utilization, political pressure kind of mounted in the American College of Surgeons and the American College of Emergency Physicians helped this along tremendously by issuing statements declaring focused ultrasound within the scope of practice for those in their specialty, which something the internal medicine and family medicine community should definitely take note of. So in 1999, everyone finally kind of agreed that the FAST stood for Focused Assessment with Sonography for Trauma, and recommendations on credentialing were made. And sort of building on the work of French intensivists and trauma surgeons working on ultrasound projects with NASA, 4 additional ultrasound views for traumatic pneumothorax and hemothorax were added to the FAST exam in the extended or EFAST exam, which is used in most trauma bays today. So that was a little bit of lung ultrasound, and then much of the early clinical bench work on lung ultrasound came from Daniel Lichtenstein, who throughout the 1990s and 2000s tirelessly published his findings and methods to diagnose not only pneumothorax but also pulmonary edema and pneumonia to identify the cause of respiratory failure in ICU patients. And this craft was refined and added to by many experts across the world over the years. And in 2012, an international consensus conference led by Giovanni Volpicelli helped define the state of the evidence about lung ultrasound and standardize the method for widespread use, and it's taken off from there. This is not to say that the methods that are shown here is the only way or the correct way to utilize lung ultrasound, but it's certainly the best starting point for beginners, and this paper is really a must read for anyone serious about learning the expanding applications to lung ultrasound. So with critical care community increasingly interested in focused echo in ICU patients, hybrid multi-organ protocols began to emerge combining heart, lung, and abdominal ultrasound to determine the cause of shock in critically ill patients. The most well-known of these is the RUSH protocol popularized by EM creator Scott Weingart, whose podcast is definitely worth a listen. And that said, there are numerous ultrasound protocols for the critically ill or dyspneic patient, most of which center around some component of cardiac IVC and FAST exams. So what about generalists, though? Sandwiched between the ER and the ICU, the internist shouldn't be left out. Just because a patient hasn't had trauma doesn't mean that detecting free fluid in the chest or the abdomen isn't useful. And increasing literature suggests it is useful to the generalist in numerous settings, and both the acute and chronic setting, and where generalists really have a role is in the monitoring of their patients. And some of those most interesting applications, I think, coming out of the infectious disease side, where you see the EFAST being applied to triage patients with dengue fever who are third spacing and having high risk of complications, or in regions in which there's a high prevalence of HIV and TB, and performing sort of a modified FAST exam that also looks for abdominal lymphadenopathy and takes into account the spleen is incredibly useful beyond traditional ultrasound or traditional exam skills in identifying and managing these patients with extrapulmonary TB. And there's a good podcast on the ultrasoundpodcast.com on this topic if you're interested in learning more. So I've heard the FAST exam sort of referred to as the gateway drug for point-of-care ultrasound, and I like that concept a lot. And for the vast majority of providers, I think that this is true. But for generalists, I have to say that the heart and the lungs are really really important, and the cardiopulmonary limited ultrasound exam, or CLUE, really does appeal to the desire to kind of put the sort of puzzle pieces together, combining left heart, pulmonary, and right heart physiology. I think Bruce Kimura, forward-thinking cardiologist at Scripps, crafted a very simple yet highly useful ultrasound tool for evaluating the dyspneic patient, teasing out, whether or not the patient had COPD or heart failure exacerbation. And the successful application of this protocol in my own practice was a significant factor in determining my kind of career decisions to pursue an ultrasound fellowship, and has remained kind of a core component of my what I use at the bedside in terms of an ultrasound physical. So with that, I'll turn things over to Janice, and she'll tell you about kind of her story.
Hi, everybody. Thanks for tuning in. I'm Janice Boughton. I'm an internist and a hospitalist in Moscow, Idaho. I wanted to tell you a little bit about how I got involved with bedside ultrasound. I've been in practice since 1990 as a traditional internist. In 2011, I took a sabbatical from my practice, and I experienced my first bedside ultrasound course. The teachers were emergency medicine physicians from Harvard Medical School. At that point, I went from thinking of ultrasound as blurry pictures, mysteriously deciphered by radiologists, to understanding that I, too, could potentially use it to see what was going on inside my patients. So I went home and I practiced, and a few months later, I bought myself a pocket-sized ultrasound machine. I used what I'd learned in my emergency medicine course, and I added ultrasound to my routine physical exams, pretty much starting the week after I was done with that course. I learned a lot by doing ultrasound and comparing it not only to other imaging, but also to my findings on history of physical. I took more emergency ultrasound courses, and I took an online course from the American College of Chest Physicians in cardiac ultrasound. In 2013, I got even more serious, and I took a month off from my hospitalist jobs, and I completed a mini fellowship in ultrasound at the emergency department of the University of California at Irvine. There I had the opportunity to review hundreds of ultrasounds that I'd done with emergency ultrasound staff, and I helped to teach and supervise medical students who were learning bedside ultrasound there. So wasting no time, later in 2013, I went both to Tanzania and South Sudan to teach ultrasound, and I have continued to have fun with it ever since. So as I adapted what I'd learned from emergency physicians and intensivists to my own general medicine and hospitalist practice, I gradually fell into a routine. Initially, I called my routine heart and fast, which meant for me that I would look at the heart and then I would do the focused assessment with sonography and trauma, which assessed the abdomen for fluid in spaces where it shouldn't be. Gradually, that morphed into what I thought of as the internist's ultrasound exam. I wanted to be able to teach that exam because it had become so natural as part of my assessment, so I talked to Mike Wagner about it. It turned out we both developed about the same quick ultrasound physical. So we wanted to make it easy and memorable and accessible to students and doctors like ourselves. So PEARLS was the mnemonic that we came up with for teaching it. It stood for next slide, parasternal, epigastric, apical, right upper quadrant, left upper quadrant, and suprapubic. These were the locations that the ultrasound transducer would be placed to help evaluate the patient in the ways where the physical exam was weak. So next slide. Those locations would evaluate the heart for a pericardial effusion, left and right heart failure, gross valvular dysfunction, chamber size, and approximate central venous pressure. Scanning the lungs would show pneumothorax, pulmonary edema, pneumonia, and pleural effusion. We could see if the liver or spleen were enlarged and sometimes see whether there were gallstones. We could see hydronephrosis, urinary retention, and sometimes kidney stones or other parenchymal kidney disease. We could accurately evaluate whether our patients had ascites. My routine in Pearl's exam has developed subtleties over the years. Oftentimes it hops back and forth between a standard physical using palpation and inspection and auscultation, and then imaging with the ultrasound. I often find that my patients are really interested in what I'm seeing, and they become more engaged in the whole process when I show them what I'm doing. So sometimes I'll have them hold the machine while I point out the pictures. Here's a little video showing how I might do that in an office setting. So here I'm pointing out to the patient the pericardium, which is the bright thing at the bottom. As I look at his heart pumping, usually I'll tell him, "You have a beautiful heart." That seems to make him happy no matter what shape they're in. There's the 4-chamber view. It's easier for the patient to understand the heart in that view. And then I switch over to the right upper quadrant view, and I'm showing the patient how his diaphragm moves as he breathes. I might show him where the kidney is and tell him that his kidney looks great and it doesn't look like there's any blockage. And I'll reach over and nip under the left side of the gown and show him his left kidney and explain that his lung looks good and I don't see any fluid where it shouldn't be. And after that, I'll show him the lung again there. And here I'm looking at his epigastric region, showing the shadow of his spine and his aorta and inferior vena cava. I explain what I'm seeing with that. Tell him your hydration status looks okay. And then I'll nip on down to the suprapubic and tell him what I see with his bladder and point out his prostate in that case, and let him know what I can tell from that. So
okay.
I think we're.
So I'm going to do a quick demo. Yeah, quick demo video. So I think one of the challenges is that we hear a lot is that you know, especially for folks in primary care or busy hospitalists, that you know they don't have time to perform bedside ultrasound. They're simply sort of too busy. And I think that there are certainly some legitimate concerns to that. And I think when you're first starting out, just like learning any kind of new skill, you're going to be a lot sort of slower, and things are going to take sort of more time. But that being said, this examination does not have to take an extensive amount of time. And so we created this video just to kind of sort of show and compare how an ultrasound physical exam can kind of look compared to a routine physical exam. So on the left-hand side of the screen, you'll see me performing the sort of Pearl's different views in terms of an ultrasound physical, and on the right-hand side, you'll see me kind of do a thorough physical using a stethoscope in my hands as far as palpation and percussion is concerned. This is just not an all-encompassing physical by any stretch of the imagination, but this is just sort of if we were being thorough and looking at the heart, lungs, and abdomen. And so we'll start off similar to what Dr. Kimura does with a clue protocol with a big glob of gel right on the chest and come back to that, looking at the peristernal view, kind of taking a quick peek at the heart, looking for pericardial effusion and LV function, chamber size like left atrial dilation, aortic root enlargement, and right ventricular enlargement. And then we'll go over to the apical views, compare the right side to the left side of the heart. Swing down into the epigastric views, slide in, follow the IVC into the right atrium of the heart, look at the subxiphoid view of the heart, and then kind of follow it back down and maybe look at the aorta and the IVC, compare the two. And then here's the IVC in the long axis, taking a look at estimating central venous pressure and volume status. Swing over to the right-hand side, you'll take a look at the base of the lungs, make sure there are no B lines in the base of the lungs, look at the kidney on the right, look at the liver on the right, make sure there's no free fluid. You can look at the gallbladder and the IVC and the aorta in this view, but mainly just kind of get a sense of whether or not that liver is enlarged, whether or not there's any free fluid. Come over to the left-hand side, start and use the spleen as the acoustic window instead of the right where we use the liver. And you'll just see the spleen and the kidney there, assessing for hydronephrosis, but also checking out the base of the left lung, making sure there's no pleural effusions or pneumonias. And so once you get a sense of all that, come down to the suprapubic view, and you can use just one probe for this, the multi-phase array probe, and look at the bladder, use the bladder as the window. If the bladder's not full, obviously you're not going to see very much, but you can look at it in both transverse and sort of long axis and get a sense of, you know, bladder size, if there's any masses or stones inside the bladder, and then using the bladder to see things like the prostate or the uterus. So overall, it takes about 2 minutes to perform once you get the hang of it, and it can be a layered exam, meaning that you don't have to assess for all of these things. Certainly when you're a beginner, the main thing you'll look for is just fluid where it shouldn't be, so pericardial effusion, pleural effusion, and ascites. But you can use these windows and these views to evaluate for all of these different conditions. And it's fairly accurate, and certainly much more accurate than our sort of traditional exam. And just like with regular physical exam findings, you're going to want to sort of think about and synthesize kind of these images in the context of your other exam. And what I really like to do is make sure we review them with the patients and make sure they're engaged and things like that. So hopefully that's helpful in terms of kind of understanding what we're talking about when we're talking about an ultrasound physical exam. I think a lot of times people get a little bit confused as to what we mean, and it's difficult to know that unless you see it. And so now I'm going to turn things back over to Janice. We're going to go over some normal versus abnormal views with what sort of pathology can be detected at each of those different sites.
Hi again. I usually will start with a peristernal long axis view of the heart. That's a standard echocardiography view with the transducer placed diagonally to the left of the sternum. That view is very good for looking for pericardial effusions and left ventricular function. In this slide, we see the normal heart on the left, kind of lounging on its side with the bright white pericardium below, and the mitral valve, aortic valve, septum, and part of the right ventricle in view. The arrow indicates that the pericardium is right next to the muscle of the left ventricle. On the right, we see a rim of black around the heart between the pericardium and the heart itself, indicating a pericardial effusion. The next slide shows a normal heart on the left with the muscle of the left ventricle contracting evenly and the mitral valve slapping the septum during diastolic filling. On the right is a heart that is failing with a large left ventricular cavity and a weakly fluttering mitral valve. The ventricle wall is barely moving, indicating a very low ejection fraction. We mostly just eyeball the ejection fraction, and I'll usually say that systolic function is normal, slightly reduced, or severely reduced, rather than giving an actual number. Sometimes I'll also say hyperdynamic, which means that the endocardium is nearly touching in the middle. In the next slide, we focus more on the base of the heart. Looking there can identify left atrial enlargement by visually comparing the left atrium to the aortic root. Usually these are about the same size, and an atrium that is larger than the aortic root is usually enlarged. This often indicates ventricular dysfunction, especially diastolic dysfunction, and is also present in valvular heart disease and congenital heart disease. This slide shows the rule of thumb that in a normal heart, the right ventricle, aortic root, and left atrium usually take up equal thirds of the base of the heart. In this next slide, we see that we can also evaluate the aortic root for enlargement or dissection. An aortic root that's larger than about 4 centimeters is abnormal and can indicate dissection or a risk for dissection. So the next slide shows that the right ventricle is also visible from this parasternal long axis view. If it is larger than the left ventricle, that can indicate pulmonary hypertension or right ventricular failure. Now the next slide shows the apical view, which is a beautiful way to visualize all 4 chambers of the heart. You can get the apical view by sliding over to the apex of the heart, which is often, though not always, at the PMI, and pointing the transducer to the base of the heart. This is the best view for looking at the size of the right ventricle. It should be smaller and less muscular than the left, about 1/3 of the heart to the left ventricle's 2/3. Bowing of the septum from the right ventricle toward the left in systole indicates high pressures in the right heart, often present in severe chronic or acute pulmonary hypertension, such as with hemodynamically significant pulmonary embolus. So these slides show the normal heart on the left, the very large right ventricle in the middle slide, and on the right you see the right atrium, which is also severely enlarged, usually another sign of pulmonary hypertension. If a patient has COPD, the parasternal view can be tricky or impossible to get, and often the apical view is actually easier and can give you all the information you need. So the A of pearls can also remind us to look at the anterior lung if that seems to be indicated, but we don't have a slide of that here. So from there, we slide down to the epigastric area, where we can point the transducer up and visualize the heart again. In some patients, this is the only way to visualize the heart because with aging and COPD, the heart is low in the chest and the hyperinflated lungs completely block your ability to get either the apical or parasternal views. This is the go-to view of the heart for trauma surgeons in a hurry and can visualize the pericardium well for effusion or tamponade. In this slide, we see the normal heart, and to its right, a heart surrounded by black hypoechoic fluid with a right atrium that collapses during early diastole, which indicates tamponade. So the next slide shows that it is also the best view for seeing the inferior vena cava. It's also the best view for seeing the aorta, which we don't have a slide of. On the left-hand side of the slide, we see the normal inferior vena cava with the transducers looking longitudinally. And we can see that inferior vena cava size is between 1 and 2 centimeters, and that with inspiration it collapses more than 50%. In the middle, there is a very tiny, nearly invisible inferior vena cava, which probably indicates fluid depletion. On the right is a plump inferior vena cava, greater than 2 centimeters in diameter, and not collapsing much with inspiration. This indicates a higher right ventricular filling pressure, such as in congestive heart failure, pulmonary hypertension, tamponade, or tension pneumothorax. You can also see a plump inferior vena cava during a rapid fluid bolus, even in patients who may still benefit from hydration. And with further familiarity in the epigastrium, you can see all kinds of things like the pancreas and para-aortic nodes and branches of the aorta. You can screen for AAA. All these things can be interesting in the right clinical situation. So the next slide shows starts to show right and left upper quadrants that give us a huge wealth of information. You can see the bases of the lungs where pneumonia and small effusions can hide from a chest x-ray, and you can see the wet lungs in the case of congestive heart failure, ARDS, or viral pneumonia. On this slide, you see normal lung to the left with repeating parallel lines indicating a well-aerated lung, and on this, we call those A lines, and on the side, the right side, we see these sunburst lines that we call B lines, which indicate that the lungs are wet and can transmit sound waves. In the next slide, you can see, so next slide, yeah, you can see some pleural effusions. The slides to the left show the liver and spleen, diaphragm, and a uniform gray of normal lung. The slides on the right show black in the area to the left of the diaphragm, indicating fluid at the base of the lung. The far right slide might be a bit difficult to interpret since the fluid is a little more gray than black, but then you notice that there are repeated shadows below the lung on the bottom of the screen, which are spine shadows. They show that the ultrasound beam was transmitted through to the spine, which confirms that we're seeing fluid rather than normal lung. We call that the spine sign. The next slide shows consolidated lung. Small pneumonias in the lung bases are often missed on chest x-ray, but they can be visualized as echogenic lung tissue on ultrasound. Clinical judgment can help tell the difference between different causes of lung consolidation, from infection to cancer or atelectasis. But in this picture, you see what we call hepatized lung, which is lung that looks like liver, with white dots that move with breathing. These are dynamic air bronchograms, and they are quite specific for pneumonia. On the next slide, we see Morrisons Pouch in the right upper quadrant, and the splenorenal recess in the normal slide just to the right of that. You can see if there's a ascites by looking at the space between the kidney and either the liver or the spleen. You can also evaluate liver and spleen sizes pretty accurately by just sliding the transducer down and measuring rather than poking your patient, who would probably wish you would stop. In the next slide, we look more specifically at the kidney. The kidney is pretty easy to visualize, and a bedside ultrasound exam is quite good for evaluating for hydronephrosis. On the left side, you can see a normal kidney, which is shaped like a bean with a hyperechoic renal pelvis and a gray cortex. To the right, we see a kidney with a blacker anechoic pelvis, indicating that there's urine that is not draining adequately. Further to the right, we see this flower petal pattern of moderate hydronephrosis. In the office setting, small or hydronephrotic kidneys can be a clue to the etiology of abnormal lab values. And in the hospital, we often agonize about whether to get an ultrasound on our patients who have acutely rising creatinine levels, despite the fact that we almost never see hydronephrosis in those situations. A quick bedside evaluation can accurately rule out obstruction as the cause of the acute kidney injury. Next slide. The gallbladder often shows up in a right upper quadrant view and can be evaluated for stones or cholecystitis. Gallstones are echogenic, and a thickened gallbladder wall can indicate inflammation of the gallbladder. On the left-hand side, you see that Mike is scanning through a normal gallbladder. Let's see. And on the right, there's a larger gallbladder with a little pile of stones that are casting a shadow below. As you get more proficient, you can often feel confident in evaluating whether the common bile duct is enlarged as well. And finally, the suprapubic view. The suprapubic view is good for looking for free fluid in the pelvis. Sometimes if a patient's sitting up slightly, that is where the free fluid is going to go. For finding unexpected early pregnancies and other pelvic masses, and for evaluating the bladder for distension or masses. It's important to place the transducer right above the pubic bone, pointing down toward the coccyx. Beginners often guess wrong about this location and have trouble finding the bladder because they're too close to the umbilicus. But some of the most impressive surprise diagnoses I've made have included something as simple as urinary retention. This slide shows a nice normal bladder on the left with a squared off shape. The middle slide is an elderly patient who's been agitated with poor urine output. The nurse thinks he may need a sedative and a diuretic, but the ultrasound shows he has a huge bladder, like a beach ball, and he needs drainage before we think of any other interventions. On the right is a man I saw in clinic with fatigue and the common old man complaint of urinary frequency. Ultrasound of the bladder showed both his large prostate, which you can just see to the far right of the screen, a bilobed mountain pushing into the bladder, but also an irregular mass, which turned out to be a transitional cell carcinoma of the bladder, which was resected not long after that. And he's alive and doing well without further bladder cancer problems. So bedside ultrasound is useful every day I work, if only to confirm clinical impressions. These are a couple of cases from the last few weeks which demonstrates how it helps. These are not the oh wow cases I sometimes have where the ultrasound gallops in and saves the day, but these are the routine everyday patients when the ultrasound helps me answer the questions my exam leaves unanswered and allows me to be a better doctor. So the first case was a patient whom my colleague had admitted the night before, only a week after her last discharge, with a diagnosis of COPD exacerbation. She had been hypoxemic with an irregular tachycardia on admission and had improved with oxygen. When I saw her, she was mildly confused, with a little bit short of breath, and her vital signs were not particularly remarkable. Her heart exam was difficult to evaluate, and listening to her lungs did not help me identify the cause of her dyspnea and hypoxemia. But the ultrasound was way more interesting. So on to the ultrasound. The parasternal long axis of her heart showed a thickened left ventricle, actually a quite thickened left ventricle, which contracted, but not actually really normally. I wouldn't say that her ejection fraction was poor, but her heart doesn't seem to fill very well. The mitral annulus is calcified. You can see whiteness at the edge of where the mitral valve is. That's probably due to her age, and her left atrium is enlarged. This looked to me like a heart with significant diastolic dysfunction. Slipping the transducer under the arm of her hospital gown, I visualized the base of her right lung, which showed a triangle of black to the left of the diaphragm with some floating hyperechoic lung. I could see the repeated shadows of vertebral bodies to the left of the diaphragm, showing the sound waves were propagated through to the base of the lung and confirming my diagnosis of a small right pleural effusion. On the left side, I again saw a triangle of darkness above the diaphragm, suggesting pleural fluid. Even though it looks more gray than black, the spine sign confirms that this is not normal aerated lung. So she has bilateral small pleural effusions. And in this patient, my ultrasound exam, in addition to my history, physical, and review of her records, points me toward a diagnosis of congestive heart failure rather than COPD, and it helped me fine-tune her therapy, so perhaps she will stay well for longer and not be admitted to the hospital so soon next time. The next case was a young man with multiple yearly admissions for diabetic ketoacidosis. I think we all have met these people. He's lying in bed, he's miserable, he's vomiting, lethargic, and he's breathing deeply with irregular tachycardia. His heart and lung exams were normal, and his abdominal exam only showed some mild, non-localized tenderness. On ultrasound, his parasternal long axis of the heart shows it to be perfectly active. In fact, hyperdynamic, with the walls of the left ventricle touching each other in systole. Mike, have we, yeah, we're there. This particular clip is a little off axis, which does exaggerate that, but I had slid through the heart exam, and it was true. We see the hyperdynamic contractility in patients whose normal hearts are stressed by the need for a high cardiac output. And in this case, it confirmed my clinical impression of an ongoing fluid deficit and assured me that he had no evidence of myocardial ischemia. When I slid to the epigastric view, I can see his small collapsible inferior vena cava, which is still small despite 2 liters of normal saline and a third that's going in. So I can conclude that he still needs more fluid. In the right upper quadrant, I can see the base of his lung, the liver, and a bit of his inferior vena cava. This view is often the best place to see the vena cava if the epigastric view is difficult because of gas or a surgical dressing. I can see the base of his right lung, which is normal and reassuring, confirming my clinical impression that there is no pneumonia, pleural effusion, or pulmonary edema. But his left upper quadrant is a little more interesting. Usually in the left upper quadrant, I'd expect to see the spleen, the kidney, and the base of the left lung. In his case, I see an enlarged dark structure with white blobs floating in it where the spleen should be. So this is the stomach, and despite copious vomiting, he has a full stomach. Above the diaphragm, there's also some darkness, but that's a mirror image of the distended stomach, and we can see no spine sign. So, the lung is fully aerated and normal, but the distended stomach might indicate that he has gastroparesis and may help explain his frequent episodes of diabetic ketoacidosis. Of course, also his problem of not using his insulin regularly is probably a bigger issue. But visualizing a distended stomach has often been game-changing in situations where I actually didn't suspect it clinically. Now we're going to transition to Mike, who has a couple of really cool cases.
So this first case is, I'll say, a middle-aged female who presented to the clinic with a chief complaint of, I think I pulled a muscle, had been moving some furniture, that sort of thing, and was having some right lower quadrant abdominal pain. So initially when I sort of was having this discussion with the patient, I was thinking I was going to find maybe a inguinal hernia or really no significant findings. But placing the probe in the right upper quadrant and getting that right upper quadrant home screen view there, there are immediately some cause for alarm. And there's 2 findings here that are not normal. We'll go over those. Hopefully you can kind of guess them. Let's see. And then also kind of moving down into our suprapubic views, there was a decompressed bladder, but I still was able to kind of see some structures through some blackness there, which was not related to her bladder. So, ultimately, in terms of what was going on, you can see here that there's free fluid in the abdomen. There's fluid in Morrisons Pouch that you can see in the ultrasound image right in here, in between the liver and the kidney. And the kidney itself has some evidence of hydronephrosis. And so that's obviously a concern in a middle-aged female presenting with the abdominal pain, especially when we pair that with her pelvic images. So here's the orientation of the transducer compared to the CT, and you can see that this represents a complex ovarian mass with surrounding free fluid and pelvic ascites. And so sort of right away that was able to kind of help me triage the patient in this quick 15-minute acute appointment, was able to kind of not sort of falsely reassure her that she probably just pulled a muscle or had a small hernia or something like that, and able to rapidly get her the imaging she needed and the subspecialty referrals within kind of a week of her seeing me. So that was nice. And certainly unexpected in terms of the finding, and only kind of came about because of the fact that we routinely include the ultrasound as part of my exam. So this next patient was an elderly abdominal male who came into our clinic complaining of abdominal pain, poor appetite, and dyspepsia. and probably would have gone down this sort of dyspepsia route and you know, prescribed PPIs and sort of maybe tested for H. pylori and things of that nature, but on kind of a routine examination while getting that epigastric view and looking for his heart there, sort of slipping into this view here, there's something in between the heart and the liver there that should not be there. And what's happening here is I'm sort of pressing with the transducer kind of up and down in the epigastric area at the site that he's sort of maximally tender, and seeing that there's sort of a collection, a mass right in this epigastric region. Moving on to the left upper quadrant view, all his other views were pretty much unremarkable, but his left upper quadrant view was, he had a normal looking kidney, a couple of small little cysts, but that spleen had a very unusual echotexture to it, kind of had a moth-eaten appearance. And with the findings of the sort of cluster of grapes inside his abdomen, I was very concerned about enlarged lymph nodes in the aorta. And I only recognized this finding because of the educational material that I had found kind of looking at the FACP exam, you know, for HIV-associated tuberculosis, and recognized that what I was seeing was actually abdominal lymphadenopathy, and that those changes in the spleen there were in fact related to that abdominal lymphadenopathy, and so infection and hematologic malignancy rose to the top of my differential, and given his age and things of that nature and lack of risk of infection, certainly malignancy kind of came to the top. So we very quickly got him some additional imaging and diagnosed him with lymphoma and got him to the oncologists. And so that being said, certainly not all of the point-of-care ultrasounds that we do end up with a cancer diagnosis, but certainly it was one of those things where Janice had convinced me to add more routine use of the suprapubic and bladder view after we had initially talked about this, and certainly to my benefit, so thank you very much for that. I had abdominal pain, patient with abdominal pain and diarrhea, and maybe kind of some debris coming from the urine. Placing the view over top of the bladder, you can see in the transverse plane here, there's the bladder here, but this little thing's kind of bubbling up here should not be there in the bladder. And if you look in the long axis, you can see the lower portion of the bladder here, but at the upper portion of the bladder, there's artifact that kind of looks like lung, but it's inside the wall of the bladder. So what we're looking at here is actually air inside this patient's bladder. And so you can actually see air bubbles kind of coming up through the back wall of the bladder and kind of bubbling up and hitting the top and going in and collecting in a fashion there. And so this was somebody we were able to quickly diagnose as having a fistula as the cause of the recurrent urinary tract infections. So now we'll kind of wrap up with our cases and just sort of go over a couple of salient points in terms of our experience about you know, using routine ultrasound as part of our physical exam. Janice, do you want to start, or do you want me to start?
Oh, you go ahead.
So I guess one of the things that we feel very strongly about is that this exam is something that's very scalable, and so there's a lot of different viewpoints in this exam, and the scope of the exam can be quite broad, which is a little bit daunting for beginners when they first start. But that's not to say that everybody should be looking, you know, at the gall bladder, or everybody should be irrigating the aorta, or doing sort of some of those advanced skills. It's one of those things where you can start off relatively basic and then have it expand over time. I think, you know, for me, one of the couple important points that I wanted to make sure I emphasize is this concept of a multi-organ ultrasound exam is certainly not new, that the technological developments and the cultural changes happening in medical education have resulted in shifts that have made this more feasible than ever before. And I think that this is important if we're trying to bring the emphasis sort of back to the bedside. Many of the views and the diagnostic targets that we have very strong or at least decent evidence base that with higher likelihood ratios than a lot of our traditional exam skills. So for those of us who are really trying to emphasize the bedside exam, I think this is absolutely a tool that can help us bring the emphasis back to the bedside because it is so useful. For some of the folks that a common argument we get is that we're just putting one more piece of technology in between the doctor and the patient, and hopefully what we've done at this point is kind of show you that's not true at all. This is just like any other physical exam tool in the way that we use it. And one of the things that has helped me as a junior clinician is that I actually take a better history as a result of my ultrasound. I ask questions in a more thoughtful way and in a more intuitive way in some regards, but also something that it's just a better tool. I feel better with it in my hand, and it's one of those things where I can integrate it as we're interacting, and it doesn't, since unlike with a stethoscope, patient has to kind of be quiet as you're examining them, we can kind of continue the exam during that process.
Right.
Another important thing. Sorry.
Oh, sorry, I'm interrupting you. One of the things that I've noticed is that while I ultrasound, I stop talking, which gives the patient a time to talk, which so it actually helps this whole exam skill of listening. Oftentimes the patient will start talking about the thing you're looking at. You know, oh yeah, I remember I had that heart attack 10 years ago, or something completely unrelated. Yep. that you really wish that you're really glad they said, like, yeah, I did much better when I was taking my psych meds, you know. So it's and it really actually brings me closer to the patient because of sort of appreciating their insides along with them rather than when they're not even in the room.
And then I think one other thing I want to address is this idea that ultrasound is operator dependent, which is an argument that kind of frustrates me because what tools in medicine do we have that are really not operator dependent? But that I don't think that that's an argument for not doing ultrasound. I think what that is an argument for is increasing the amount of training and standardizing the way that we train folks. So we're incorporating this sort of ultrasound physical into the examination of our medical students here at the University of South Carolina. This is something the second-year medical students will start to learn, and then we'll build on that skill set once they hit the third and the fourth years. And they might not become experts, but certainly they will be better than where they were without this skill set, which I think is an important point.
For those of you who are mature physicians thinking about picking this up, I felt like I was actually a better clinician as soon as I was able to get ultrasound views. So now that's not saying that I could get ultrasound views from the very first moment, but it wasn't more than weeks before I was getting extremely useful ultrasound views. And so long as you don't have an expanded idea of your abilities, there are certain things on the ultrasound that are just intuitively easy to interpret.
So with that, I think we'll kind of wrap things up and we'll start trying to address a couple of the questions. Let me see if I can go ahead and do this. Hopefully. Darcy, I don't see some of these questions.
That's okay. I can read a couple to you.
Okay, that's good.
That way you both can answer them. The first question I have is pocket ultrasound a billable procedure? And if so, what are criteria needed for billing bedside ultrasound?
Okay. Yeah, I can answer that question. So the It is a pocket ultrasound is a limited procedure. You can bill it as a separate procedure than the standard physical examination. I'm a little opinionated on that, but in terms of the technical aspects of how you do the billing, actually, I would refer you to another great AIUM webinar by Paul Bordeman, who did how to do the billing and credentialing kind of for the primary care. So we'll do another question.
Okay. Well, here is, does point-of-care ultrasound need to be followed by formal study?
Janice, do you want to feel that
I'll
one?
take that one. I would encourage people to think of point-of-care ultrasound as like your physical exam. So if you find something on your physical exam that you don't understand or you think needs more clarity, you get a formal study. There's a lot of situations in which my point-of-care ultrasound doesn't need a confirmatory study, and there are several. Like Mike showed you a couple of really cool cases, and he's not going to entirely count on his ability to read those interesting little grapes near the aorta as being lymphoma without having a CT scan. Same way with the lady with the pelvic abnormality or the guy with the bladder fistula. So no more or less so than your physical exam, I'd say.
Okay. Could you please describe the differences in visualization? You have to apologize my pronunciation of acidic fluid between the RUQ and LUQ.
Yeah, that's a good question. In the right upper quadrant, the fluid will tend to, in a person who is supine, and I think that's a really important point, the patient has to be kind of laying completely flat. The most dependent portion in the abdomen becomes the space in between the kidney and the liver, which is called, referred to as Morrisons Pouch. And that's where you will hunt for free fluid. A key aspect is also making sure you visualize the tip of the liver as you kind of bring the probe more caudally, as fluid will sometimes collect there. On the other side, on the left upper quadrant, the fluid will tend to collect just above the spleen, actually, and intends to not collect all the way down into the space in between the spleen and the kidney on the left-hand side. So usually you have to be a little bit more cephalad and a little bit more posterior to detect fluid on the left-hand side.
All right, and here's one. How specific are the lung findings? For example, pneumonia and pulmonary edema, as it is known that ultrasound is not really helpful examining gas-filled organs like intestine and lungs.
I have to have this question. So, I would strongly encourage you to at least check out the International Consensus Conference publication in 2012 on the use of lung ultrasound and its many sort of diagnostic applications. But that being said, even in Annals and New England Medicine, Journal of Medicine, Journal Watch, and these sort of review publications that track these, there have been a number of meta-analyses on lung ultrasound, specifically looking at lung ultrasound for the diagnosis of pneumonia as well as lung ultrasound for the diagnosis of pulmonary edema. And the sensitivities and specificities from these meta-analyses are certainly greater than 90% and a lot of times close to 95 to 100%. And I think the days of getting a chest x-ray, I think that certainly a chest x-ray has phenomenal applications and a lot of times is a very useful clinical tool, but in terms of hinging our medical management on either our auscultation findings with a stethoscope or a chest x-ray finding in patients with pulmonary edema and pneumonia, I think those days are numbered, and I expect in the next 5 to 10 years we'll see it sort of progressively fade away as more and more people become comfortable with lung ultrasound. But that being said, I mean, lung ultrasound, when you first start looking at it, it's kind of like looking at magic eye paintings or EEGs or EKGs. It initially kind of like looks like squiggles and it's confusing and things like that. But after a while, you kind of recognize normal artifacts from abnormal artifacts, and it becomes quite fun actually.
So and I'll add, one of my favorite ultrasounds is of the intestines. I think I've made a lot of difference to people by ultrasounding their intestines. And it's not, you're not ultrasounding air-filled organs so much as the areas of them that are wet. So the intestine isn't always filled with air. In fact, a lot of times it's filled with fluid, and the wall of the intestine is really easy to see if it's filled with fluid. So intestinal ultrasound is great, and there are some good articles out there about how effective ultrasound can be for diagnosing small bowel obstruction.
Okay, and I have a few questions here asking you to clarify what you meant by the spine sign.
Cool. All right, so I said the spine sign, so it's my turn. I understand that, unfortunately, those ultrasounds went by really, really fast. But when you do a right upper quadrant, or left upper quadrant actually, but more often right, ultrasound, you'll see below the areas of interest, before that, below on the screen, your liver and your lung, you'll see some other cool stuff, which will be things like an aorta, which is further in, or an inferior vena cava, and then below that, you'll see the spine, and oftentimes you won't even bother to see it. It's like that gorilla walking through on the viral video. You don't actually see the spine because you're not looking for it, but what you are seeing is these repeated shadows at the bottom, and that is your spine. So you can see that, and if you look at it, if it stops right at the lung, then that means that you're not able to see down to the spine in that location, because the lung is filled with air and therefore is keeping your ultrasound from reaching the spine. But if it goes all the way through and you see the spine where the lung is below where the lung's supposed to be, that means your ultrasound is transmitting through either fluid or wet lung.
And I'd just add that if you go to the University of South Carolina School of Medicine Ultrasound Institute, we have a YouTube channel that has a lot of useful tutorials on, it's meant for our students, but anybody can access it. And there's a great little short tutorial on introduction to lung ultrasound. That goes over pneumothorax, pulmonary edema, and pleural effusion, and it has some animations on there, and hopefully the things like the spine sign and B lines and things like that. If you watch that video, it'll be a little bit more clear. I kind of had to scale our presentation down to kind of make sure we covered everything, so we couldn't go into super details for the lung ultrasound, even though it is my favorite topic.
Yeah, this should have been a half semester course rather than a 1-hour webinar.
Yeah, absolutely.
Okay. Well, and on that, we are going to have to wrap things up. So thank you very much to our presenters, and on behalf of the AIUM and the ACP, our thanks to all of you who participated in tonight's webinar. Please remember to complete the post-test and the activity evaluation, and we hope you enjoyed this presentation and will join us again for future webinars. Good night, everyone.
Thank you. Good night.
Thank you.